so that we could move on with our presentations. So the next item on the agenda is a very interesting and very important item indeed. It's about guide wire selection by a very eminent cardiologist from India, Dr. Pratap Kumar. And this session will no doubt be very important for both the fellows and the practicing cardiologists as we are faced with critical decisions in guide wire selection in most of our cases. So without further ado, let me invite the chairpersons for this session. The session will be chaired by Dr. S. Mitra Kumar, Senior Interventional Cardiologist, and Dr. Sampath Vittanasam, Consultant Interventional Cardiologist, who will be chairing these sessions. Over to you, sir.
Yes, the next lecture is about guide wire selection, particularly in CTOs, by Dr. Pratap Kumar. He is a chairman of National Interventional Council of India, and he had been a founding member of IJCTO for the last probably 9 years. I also have attended in 1 or 2 sessions of CTO those days. He had done the maximum number of CTOs, especially the retrograde approach. There are so many other things we can talk about him. Anyway, I'll call upon Pratap Kumar to deliver his lecture.
Respected Chairperson, Dr. Sampath and Dr. Mitra Kumar, and the august audience. Actually, the topic they have given me, the guide wires selection in PCI, but I deliberately changed to CTO. So the point is actually, whenever you do CTO, it should be a planned procedure. You should do a bilateral angiogram from both sides. And people just do a CTO by just casually keeping only one-sided angiogram. That is not right. You should have a bilateral angiogram, either it can be biradial or bifemoral or femoral and radial. My approach is always bifemoral. An angiogram usually must visualize the collaterals and distal vessels beyond the CTO. And always when you do CTO, you can have a mortality, especially 2% of the failed patients can have a death. So that is to be explained and understood by the operator as well as the patient. So when you do a CTO, it should be a planned procedure. I told you, I'm not going to details of the wires and all. Usually what I do is an escalation strategy, that is an antegrade CTO. Antegrade is the first thing to learn, then only you can go to retrograde. The antegrade is actually, you have escalation strategy. Earlier and all, tough wires where we have to use only over-the-wire balloon and there is no microcatheters. And now there are excellent devices to be successful in CTO. The first wire, usually I try to take a polymer coated wire. You can choose anything. These are all wires in the Asahi group. That is actually my usual wires of strategy. I start with preferably with the Philrepsy to take the wire with the microcatheter into the lesion. Then I shift over to the first wire. I take an XTR. Some people take an XTA, but I take an XTR. This is useful for both for the retrograde as well as antegrade. Then if the lesion is not crossed, then you have to go to the next wire. I usually prefer now Gaia second. Gaia second will be obsolete in another 1 year time when the Japanese completely deplete the stock of Gaias, and then they will supply Gaia next to you. And Gaia next is available only in Japan now, and they will give you Gaia next to us also in another 1 year time. Then I go to the tougher wire like Miracle 6 or UB3, Ultimate Bro. And there is Miracle Neo wire came that is again available in the US and in Japan, not in our country, or I don't think in any other country. Then I go to the toughest wire, that is the Congress Pro 12, where you have a penetration wire. And you can actually, sometimes, from Gaia second, you can switch over to the Gaia third or a Gladius wire. So when you cannot cross with these wires, the next approach will be a parallel wire technique. You keep the wire on the one side and take the other wire. And you can have an Ivers-Garand approach, you can have antegrade dissection re-entry, a retrograde approach. I'll just go to the thing. I'll just show one case. This is actually a RCA CTO. They look like CTO starting from. What are the problems of this CTO? This same patient had a lesion in circle, and these are all, I'm not discussing, that's the only point. So this CTO RCA, you can see when you just allow the injection to go, you can see the distal vessels, and there will be a segment. How do you identify that? It's a CTO. You can either do an antegrade or retrograde. Here the retrograde position is difficult because of the ipsilateral collaterals only, not the heterocollaterals. So the JCTO score is actually defined as the blunt, the end is blunt, and is a non-tortuous, non-calcified, and it is more than 20 millimeters. Since it is not attempted early, it will be score is only 2. So it's a blunt and more than 20 millimeters. But there is a side branch at the occlusion that actually is a negative point for the CTO entry. Whenever you take the wire will go to the side branch. So which catheter, which wire or microcatheter? We actually start with the JR 3.5. Ideally, the catheter should be an Amplatzer because a tougher wire will be nice for that. I tried with the filter FC wire. The wire did not go. Then what I did is actually I kept the wire into the side branch. That is actually, you can do an anchoring there. So I kept the filter FC into the side branch. So when I kept the filter wire into the side branch, next I told you the next gradation of wire was XTR. XTR I did not go because I understood the lesion is very tight. I just went with a fine cross with a Gaia second, but the wire was not going. I was thinking there is a friction created, so I removed the wire. There is other options at anchor wire. I kept a wire. Second is an anchor balloon. You can take a balloon into the side branch and do, and you can switch over to the AL1, Amplatz 1, or you can take a more tougher wire or combination of all these things. So there is a friction of 2 wires. I took the other wire out, but even then no chance. Then the next series I went into the Miracle 6 wire with a the fine cross is there is a microcatheter. But if you can see that, I don't know, it is going up. So the Miracle 6, you can see the wire has gone out of the vessel, totally out of the vessel. Once it is totally out of the vessel, the next game is actually, I took the Gaia second wire. It is again out of the vessel, distally. So the last, but choice is actually retrograde. Retrograde is not a possibility in this case. So I went to the Congress Pro 12, that is in the lumen. Once it is a very, very tough wire. It can perforate anywhere. So I actually redirected the wire into the PDA. It is in the main lumen. I took a small balloon, 1.25 Panthera, Ryujin and all, balloon dilated. I with a 2.5 into 10-15 millimeter balloon. Again, I dilated with a 2.5, opened the vessel, but this is not the thing. You have to shift over to this wire with a microcatheter. Congress Pro 12 wire in the PDA, but I wanted to preserve the PLV, so I took the initial filter FC wire into the PLV. So I removed the Congress Pro 12 wire, then I dilated with the higher balloons. Finally, I went with this long stent and finished the case. So this is the final angiogram for the patient. So my approach was the first wire was an XTR, second wire is a Gaia second Miracle 6 or a UB3, third wire is a Gladius or a Gaia 3 or a Congress Pro 12. Always with a microcatheter, retrograde injection is mandatory. In this case, it was not needed because there is no filling from the other side. You can use a parallel wire technique or a redirect. What is actually your approach? CTO is actually an antegrade approach. You can have a single wire technique or a parallel wire technique. If you go to retrograde wire cross, creasing wire cross, cart or reverse, I'm not going. When the wire is actually crossed but not in the right track, what are the things we can do? You can redirect the wire, you can do a parallel wire technique or a dual lumen catheter. I was getting this is an example. A case 1, CTO circumflex. The wire is actually look like it's Gaia first actually not crossed. I tried with a Gaia second wire. The Gaia second wire is actually out of the track. Once it is out of the track, what are the things you can do? Either you can keep the wire there and take a parallel wire, or you can do, this wire is actually, can have a staining on the distal part. But what I did is, I redirect the wire. The redirecting of the wire is easily possible with the Gaia second. So the wire went into one branch, I taken the wire back and wire went into the same. That is actually called redirecting the wire. So this situation actually, another case, where the LED lesion is crossed, not crossed with the filter FC, we tried with the Gaia second. You can see that the Gaia second wire is out of the track. Once the Gaia second wire is out of the track, this is called the parallel wire technique. The original guide wire will prevent the entry of an additional wire into the subintimal space. So what you do, you can redirect a wire inside the body of the CTO or puncture the distal cap of the CTO. So the distal true lumen should be visualized via collaterals from the angiogram. That is a prerequisite, and definitely the skill is required. So wire enters the subintimal space. The second wire is advanced next to the original wire through a second microcatheter, which is called seesaw technique. If you don't use a second microcatheter, we call it parallel wire technique. You can use a dual lumen catheter. So the parallel wire technique is actually like this. You take the second wire. The first wire is in the microcatheter, the second wire is taken into the other. If you take both the guide wires in two microcatheter, which is called seesaw technique. So I'm not going to details. So the second wire, the wire used should be a stiff and a highly torqueable wire. The Gaia's various series wires preferred, and you can use a polymer coated jacket wire called Pilot 200 also. The second wire should be stiffer than the first wire and should have a superior torqueability. So this same case I'm coming back. So my wire is in the side branch. So what I did is actually I've taken a parallel, kept the second wire, Gaia second as the wire, and taken the next wire actually as the Gaia third wire. See, the lumen I can identify very clearly. If you watch carefully, I'm trying with the Gaia third wire and trying to enter into the true lumen. So the wire enters the true lumen. Once it is in the true lumen, you should verify clearly. I told you the angiogram to be done and understand whether you are in the true lumen. Once you are in the true lumen, you push the wire down, then the job is finished. So now the first wire to be taken out and finish the case by an injection, and this is the result. So the advantage is actually in intra-occlusion tortuous. The first wire stretches the vessel favorably, modifies the curve, especially when you go to the RCA. The parallel wire technique advantage is actually it stretches the wire and keep the vessel cost. This is actually courtesy to Dr. Gerald Werner. It's a John Werner's article. Just keeping the stretching, the first wire will stretch the vessel into the right line, then it will be easy. So dual lumen catheter comes. We have a lot of dual lumen catheter. Available dual lumen catheter in my country is Crusade only, but you have Sasuke also available in Japan, and the other things are available in. So dual lumen catheter, you have an advantage. You can enter into the side branch. This is actually the Crusade, which usually I use, but you can help for the parallel wire technique or wire the CTO with a bifurcation at the proximal cap, bifurcation at the distal cap, and this is used in this one. So use of a dual lumen catheter for achieving the distal true lumen entry using antegrade crossing attempts once the first guide wire enters a subintimal space. For example, this case. So this is a Crusade. You can see two markers in this wire. Once second marker is actually used, I'm taking the wire. I'm only showing the salient features, nothing, not the full case. So I'm taking the wire down. You can see two markers. The distal, between the distal and the proximal marker, the wire enters. And this is actually the dual lumen catheter works. So this is the way it goes. And this is another case. When something is not happening, a do or die situation, you can dilate the side branch and then create a space and then take the wire down and finish the case. Here again, the wire goes into the. If I talk very slowly, I think the speaker will. The wire goes down and finished. So problems actually, the prolonged parallel wire attempts can cause enlargement of the subintimal space and hinder the re-entry attempts. The second guide wire may follow the path of the first guide wire. And difficult to adequately visualize both the guide wires. Excess rotation wrap around the wire. Remember, when you wanted to switch over to the parallel wire, never try too much to create a larger subintimal dissection. So when you go to the why people do retrograde? So earlier CTO trials show success rate only 66 to 63 to 66%. When you go to retrograde and antegrade, the success rate goes up to 90%. So that antegrade alone 76% when you go to 97%. Retrograde approach increases. This is actually my CTO analysis. Last year we have done 365 CTOs. In that, if I take only antegrade, our success is only the antegrade with retrograde, the success rate goes up. So if you are taking only antegrade, it will be 78%. With the antegrade with retrograde, the success rate goes to 87%. So once you do an antegrade, the first is antegrade wire escalation, second is ADR, antegrade wire de-escalation, and The third is retrograde via septal collateral. And lastly, your gradation go to retrograde with epicardial collateral. So if you want to become a CTO operator, learn antegrade and retrograde approach via septal collaterals. And if you wanted to become an expert, better to learn epicardial collaterals. Thank you.
Any questions? Thank you, Pradap. Yeah. You don't use Ultimate Bro. Ultimate Bro is the next good.
I was thinking that I should go out. Ultimate Bro is available. Actually, UB3 is a very good wire. The earlier wire of Felder FC with Ultimate Bro is actually like a FC wire. With that is actually that is a with the earlier Miracle 3 together will become a Ultimate Bro. Ultimate Bro is a very good wire, especially for the retrograde. A punctured back, I use an UB3 wire.
I have. The Americans are very fond of these cross and stingray, that kind of approach. What do you think about it?
That is actually if you go to the Gerald Werner's opinion, actually, if you take the data, with the stingray crossbars, the success rate is only 66 to 67% in all the details. And if you go to the parallel wire technique, you create a success of 74%. So whether you go for parallel wire technique, which is easier one, less damaging, and stingray crossbars is useful, especially for a right coronary artery. Not for the left system, you have multiple diagonal branches and septal branches. Otherwise, you should be an expert. You should do between two branches and keep the entry there. And actually, the principle is actually when you go a knuckle wire, your space creation was not really, only a subintimal space will be there and the wire will never go out of the vessel. That is a concept of stingray crossbars.
Can I just ask you now, in our situation where guide wires are also very costly in the present economic state, we basically would like to just use one wire. So I prefer to start, if I think it's a CTO, straight away go in with the Miracle 6, where I think the results are. What is your opinion on that?
Actually, when we are doing a CTO, you should have a dedicated thinking of making it successful, where the CTO wires are actually not available, then not to do, but you can reduce the cost in different ways. I can tell you some of the ways to reduce the cost. One, if you do an antegrade CTO, you don't require always the best of the best microcatheter available. You can actually use a ETO microcatheter, keep the microcatheter just proximal to the vessel, and take an old wire to take the microcatheter at the proximal part of the CTO segment. But once you are entering the CTO segment, you should always use, preferably to try to use 1, 2, or 3 wires. But if you go to retrograde, I think you cannot try with any reused materials at all.
Another question, when do you use FC or Fielder XT? What do you prefer to use in CTOs?
No, FC is not a wire of CTO. FC is actually to take the wire microcatheter there. So if you have an LAD, LMCA LAD, there is a angle there. You enter the LAD osteoproximal part. Where if you take an XTR and bend it, then you cannot take it. So better to take a microcatheter with a FC-like wire. Reach just proximal to the CTO segment. Then try with the first wire. The first wire, I prefer XTR. And if XTR, actually as he told, can you go to the highest end of wire first as the first point? If you see a severely calcified lesion, severe fibrocalcified lesion attempted by 2-3 times earlier, then you try with a puncturing of the vessel directly, then you can go with a Congress Pro 12 or a Miracle as the first choice. But you should always keep in mind that you may be failed, but if you are actually process oriented, if you go in that level, you will understand you should not try like that.
Thank you very much, Dr. Pratap Kumar. In the interest of time, we have to conclude this session at this moment. And your lecture was wonderful with a lot of learning points. And as well as the day before yesterday, we had a very, I think you showed your skill and we learned a lot from you. And thank you very much for staying for about 2 days with us and sharing your knowledge. And hope to see you again in Sri Lanka, probably next year. And thank you very much, Dr. Pratap Kumar.
So the next session is going to be something extremely interesting for those of us who are into complex coronary intervention. It's all about bifurcation. It's a hot topic wherever you go in an interventional conference. So we're going to have a bifurcation masterclass conducted by Professor Goran Stankovic from Serbia. He will take us through a few cases, and to chair the session, may I cordially invite consultant cardiologist Dr. Vasanthi Ratnayaka, consultant cardiologist Dr. Udita Hewaratna, senior consultant cardiologist Dr. S. Mitra Kumar, and consultant cardiologist Dr. Hasanta Ranawaka.
So we are moving to the next sessions in the master class of the bifurcation. Professor R. Goran Stankovic from Serbia. Professor Goran is from Serbia, University of the Medical College of the Serbia. He has published many books with 200 publications. Even he has co-author with the Anthony Colombo, and he is a member of the European Society of Cardiology and done many interventions live in the ESC. And Professor Goran, over to you.
First of all, thank you very much for the kind invitation to participate in this meeting. I've been personally in Sri Lanka more than 10 years ago, and I enjoyed very much the hospitality, and I feel very well understanding the needs of the community and economical restrictions. Thanks for the invitation to discuss bifurcations. My conflict of interest is that I'm European Bifurcation Club member, and I'm currently the president of the club. So my opinions regarding bifurcation treatment are really influenced by the conclusion of the EBC consensus documents. So when we discuss bifurcation treatment, several randomized trials were performed, and none of them showed clear benefit associated with systematic two-stent strategy, Nordic BBC1, BBK, Cactus, and even in patients with large true bifurcations, like European Bifurcation Club 2 study, which compared provisional versus culotte, did not show the benefit of culotte. However, with longer-term follow-up, as you may see, outcomes may be even worse for systematic dual-stent strategy, and we published in 2016 individual patient data from Nordic 1 and BBC 1 studies showing that after 2 years of follow-up, all-cause mortality was increased with two-stent strategy, reaching at 5 years of follow-up statistical significance. And the most recent publication, extended follow-up of the Syntax trial, showed that 10-year all-cause mortality was higher if we treat patients with bifurcation lesions with PCI compared to patients with no bifurcations. However, there was no difference for surgical treatment, and also consistent with prior findings, two-stent strategy group had higher all-cause mortality at 10 years of follow-up. For that reason, European Bifurcation Club concludes that we should try to keep bifurcations in the simple and safe way, limiting the number of stents, but very important, its use of tubular stent to reproduce fractal geometry of coronary bifurcations with well-opposed and well-expanded stents. So for us, provisional side branch stenting strategy is the standard approach for majority of bifurcations, including the left main. And there is frequent misunderstanding when we say provisional, it's a single stent. It's not. Provisional stenting is exactly treatment philosophy to approach bifurcations in a stepwise manner, adding layers of complexity when necessary, stop when you achieve good result, and of course, whenever it's necessary, use the second stent. So we describe all the steps of provisional and available two-stent strategies in the last consensus, 16th consensus document from the EBC published in Eurointervention in May this year. And here are the steps of provisional as described by EBC. So step number 1 is crossover stenting, taking the stent size according to distal main vessel diameter. And step number 2 is to perform proximal optimization, POT. And then we evaluate the result. If we achieve optimal result after POT, we may finish the procedure at that stage in majority of bifurcations. Why we do POT? You see this 3D OCT reconstruction showing that there is a step down at bifurcation site. So coronary vessels don't taper linearly. Actually, there is a step down, and in order to expand properly the stent, we need to use bigger vessel balloon sized according to proximal main vessel diameter to deploy the stent. And here is a visible heart lab image cooperation between Medtronic, University of Minnesota, and the European Bifurcation Club. And you may see how tiny is structure of carina, and this is wire in the side branch and stent implantation in the main branch. So if we implant the stent according to main vessel diameter, what we have floating struts in the proximal part of the main vessel that we need to expand properly. And we need to keep in the lab this maximum expansion capacity table showing us what are the available maximum expansion diameters for the available stent platforms. And you may see that only Resolute Onyx has extra large vessel platform that can expand to almost 6 millimeters, which is sufficient for all left mains. If we don't do POT, again, example from Visible Heart Lab, we can go with the wire completely behind the stent and enter the side branch without going into a main vessel stent. And POT allows us, you see, to completely overlap the stent in the proximal part, expand it fully, and now we have two different diameters within the same stent, and OCT confirms good expansion in both proximal and distal part of the vessel. Why it's important to keep jailed wire? Here is the example of one of our cases in which we did crossover stenting, jailing wire into the circ. However, after stenting, we completely occluded the circ. What happens then? We can use jailed wire, like in this cartoon that I made to help our fellows learn the technique. And after losing the side branch, first we go with POT balloon distally, and then we use small balloon on the jailed wire to go behind the stent and to reestablish the flow into the circ. After that, next step is to remove the balloon, pull back the POT balloon, and then perform proximal optimization and establish good expansion of the stent throughout the proximal length of the stent. So next step after this is to go distal cell, rewire, remove the jailed wire, and then do kissing balloon inflation in order to fully expand the stent in the polygon of confluence with sequential balloon inflation and finish procedure with the final POT. After the final POT, we can remove the tissue, and you may see the spirit of provisional, which is reconstructing two different diameters with broad access into the side branch. That's why we insist on using a jailed wire technique, and this is the case that I showed you. After going with balloon on the jailed wire, we did kissing balloon inflation and achieved optimal result. However, if after POT there is suboptimal result at the ostium of the side branch, we proceed to step number 3, which is balloon, which is exchange of the wires, either using the third wire or pulling back the wire from the main vessel. Again, we go to visible heart and we show the pullback maneuver. We go with the wire distally, and by pulling back, we are able to reach one of the distal cells. Reaching the distal cell is extremely important because then we go to step number 4, which is kissing balloon inflation and final POT. And after kissing balloon inflation, we again evaluate the result. If the result is optimal, we finish the procedure with this step. Here is how a sequential kissing balloon inflation is performed with short NC balloons. And then after removing balloons, you will see that with distal recrossing, we remove the stent struts in front of the ostium of the side branch, and by kissing, we scaffold the ostium of the side branch using the stent struts from the main vessel stent. That's why Thierry Lefebvre says we stent both vessels using single stent. And you see nice coverage of carina and broad access into the side branch. Here is the example of provisional, one of my cases. For us, angiography is like GPS. It guides us to understand plaque distribution and to understand what is the risk of losing the main branch or side branch after stenting. Here is the vessel contour, and by using this interpretation, we understand that most of the plaque is actually in front of the ostium of the LAD, and the risk of occluding the circumflex with crossover stenting is very low. So my strategy in this case is provisional crossover stenting and strut opening. And here are 3 wires with 3 balloons. I did tracing and achieved optimal result based on understanding of the risk of occluding the side branch. However, if after kissing result in the side branch is suboptimal, then we go to the next step, which is step number 5, provisional side branch stenting, and there are different 2-stent techniques that we can use. What is the indication for each depends on plaque distribution. When do we achieve better result with 2 stents? This is network meta-analysis which showed us that only if side branch lesion length is more than 10 millimeters, we actually have the benefit of 2 stents. If side branch is shorter than 10, there is no difference in outcome between single stent and 2 stents. For that reason, elective 2-stent strategies in consensus document of EBC may be considered for long side branch lesions, high risk of compromise or difficult access. And this is the algorithm. If, like in my case, the expected risk of losing the side branch is low, we use provisional stenting finishing procedure with T, TAP or culotte. Depends how much we pull back from the side branch into the main vessel stent. And this is the example of diffuse disease of both branches. We know in advance that we will use 2-stent strategy, but which one is the best? Again, we assess the lumen contour, plaque distribution, again in front of the LAD, low risk of occlusion of the side branch. So I go to algorithm, low risk of side branch occlusion brings us to provisional stenting. And in this case, because of wide angle, I selected T-stenting. And this is the first stent in the LAD, second stent in the CIRC, and optimal final result after kissing. If we have 2 vessels of similar diameter, again, like in this case, with similar low risk of losing the side branch, in this case, because of diffuse disease, we select culotte with image guidance, and double kissing culotte was performed with optimal final result, confirmed by the OCT. What is double kissing culotte? It's actually provisional towards the LAD and then provisional towards the CIRC. If our estimation of the risk of losing the side branch is very high, then there are 2 different approaches. One, for experienced operators, like most operators in Asia, double kissing crush is good option. It's well-known procedure with 7 steps. And again, I show you my cartoon to understand how it should be done according to EBC consensus. So wire and predilate both branches, stent the side branch, optimize the ostium, and then crush sequentially. First with larger according to distal and then according to pot diameter. And then we go to first kissing, and after kissing we stent the main vessel, we repeat pot, recross proximally, and do sequential high pressure kissing, and after that repeat, finish with the third final pot. When we remove the tissue, you see minimal stent crush in the lateral wall with good optimal result. Here is the typical case example. Diffuse disease of LAD, left main, as well as the circ. So major risk is very high, and option in this case was by the master Shaoliang Chen DK crush. These are the steps: crushing, implantation of the first stent in the circumflex, and then crush with 3.5 according to LAD, and then with larger 4.0 balloon. This is why we crush sequentially. If we crush according to LAD diameter, because of fractal geometry, it results in incomplete crush. That's why we need to take bigger balloon, and you see that with bigger balloon, we are able, again, based on the visible heart lab experience, we learned that we need to do sequential crush. After the sequential crush with proximally rewire, do first kissing, main vessel stenting, second pot, proximal rewiring, second kiss, and then the third final pot with optimal final angiographic result. But of course, that result was confirmed by pullback by IVUS with excellent areas, distal left main 13 millimeter square, and also at the ostium of the circ, we have 7 millimeter square. The other choice, if we have major concern, is to do inverted main branch stenting across the side branch, and that results in use of inverted culotte, inverted elective T, or inverted elective TAP. For example, we go in the left main, from the left main into the circumflex, because in this case there is very high risk of losing both branches, and we decide to stent circumflex first with the inverted provisional and then do T or TAP, because it's much easier to position second stent if we go, because of angulation, straight into the LAD. And this is after implantation of the circumflex, second stent in the ostium of the LAD with TAP stenting and final kissing, optimal result. And the last option is to do, again, like in this case, diffuse disease in the distal left main. Patient was randomized in the European Bifurcation Club main study. And what we have is a major risk of occluding both branches, again, inverted provisional selected with the culotte stenting technique. And here are the steps with illustration. So first stent towards the circ, then first pot with 4.5. After that, we recross towards the LAD and open struts. And after that, we stent with minimal proximal overlap. This is mini culotte. And then we do second pot with again 4.5, 16 atmospheres. And then we do second kissing balloon inflation, and we do final pot. And this is the example of the final result achieved angiographically following the rules of inverted culotte with no angina and no shortness of breath at 1 year of clinical follow-up. For the end, I would like to conclude that image guidance is extremely important, especially for the left main, because according to British Cardiovascular Intervention Society database, image guidance for left main PCI reduced the rate of in-hospital mortality, mortality at 30 days, and mortality at 12 months. And European Bifurcation Club strongly recommends use of imaging for left main PCI. And here we published recently with Korean, Japanese, and European Bifurcation Club use of physiology for bifurcation treatment disease. And this is the algorithm helping our colleagues to understand when physiology is needed when we do left main PCI. So dear colleagues, I would like to conclude that stenting technique for bifurcation treatment depends on individual patient's anatomical characteristics, but also of operator skill, experience, and personal preference. Stepwise provisional for us is logical, straightforward, reproducible, and versatile, and remains the strategy of choice for the vast majority of bifurcations. Elective two-stent strategies, for the opinion of European Bifurcation Club, may be considered for definition 2 study criteria for complex bifurcation lesions, difficult side branch access or high risk of compromise, and we strongly recommend use of imaging and physiology to decide the appropriate strategy and optimize the result of PCI. Thank you very much for your attention. I'm ready to take your questions now and discuss contemporary bifurcation PCI.
Thank you very much for that elaborate lecture, Professor Goran. If you have any questions, it's open to discussion.
I'm Dr. Gamini Galapati, interventional cardiologist at National Hospital, Colombo. I've done quite a few left mains here. There's one technique that we use for elective two-stent strategies, which is the V-stenting. And
yes,
although it's mentioned in the general guidelines, I would like to, and we've basically had quite a few good results with long-term V-stented patients. What is your opinion on V-stenting for elective two-stent?
Yeah, thank you very much for that comment. In the past, V-stenting was recommended for 0-1-1 bifurcations, which is isolated distal main vessel, isolated LAD, plus isolated ostial circumflex. However, from IVUS, from imaging studies, we learned that bifurcations have continuous plaque extending from the left main into both ostia in more than 90% of cases. For that reason, it's very difficult to do precise V-stenting, just V-touching, touching without protrusion of the stent metal inside the main vessel. And when we extend V-stenting, it becomes SKS, simultaneous kissing stents with double barrel and long metallic neocarina. Both these techniques with proximal extension of metallic neocarina, according to all available evidence that European Bifurcation Club has, result in higher rate of stent thrombotic complications. For example, in one registry, SKS had subacute stent thrombosis rate of 6.5%. For that reason, SKS, according to EBC, is not recommended. For us, because of the extension of disease from the ostium of the LAD or the circ inside the left main, we routinely don't recommend neither V-stenting or the SKS. In both cases, we recommend provisional crossover from the left main into the LAD or inverted provisional from the left main into the circ, then pot and after pot kissing balloon inflation. So this is the position of the European Bifurcation Club regarding V-stenting and the SKS stenting.
So I am Dr. Mitra Kumar, cardiologist in Colombo. Do you have any head-to-head trial of different strategies where one strategy is better than the other? I don't see any of these strategies that permanently gives a good results. Every year the trial varies. But I still stand for the original Antonio Colombo's Minicrush. That's my favorite. I think 2003 he demonstrated, I was there. And that strategy still works very well.
Okay. Here is the position again. My personal view, I don't say that there are no other choices. At my best knowledge, there are only two trials, randomized trials, DK Crush 5 and EBC Main, which compare provisional versus two-stent strategy for left main PCI. As you nicely said, DK Crush, especially if undertaken by the experienced operators, provides excellent results. However, the difference between two trials is the following. DK Crush 5 showed the benefit of DK Crush versus provisional for complex left main disease. A lesion length in DK Crush 5 of the circumflex was 16 millimeters. For such diffuse disease, I fully agree, and I showed you the network meta-analysis for side branch lesion length more than 10 millimeters. Two stent strategies electively performed upfront provide better results than provisional. In EBC Main, the mean lesion length of the circumflex was only 7 millimeters, and this is majority of European population. In European population, diffuse disease of the circ is extremely rare. So for our patient subset, if we use EBC main study, provisional provides similar result as two-stent strategy, even resulting in some lower rate of TLR at 12 months of follow-up. Of course, for such distribution of disease, we recommend routinely provisional and use of the second stent in 1 out of 5 patients. The rate of two-stent strategy in provisional arm of EBC main was 22%, which means you don't need to plan up front if you will finish with 2 stents or with 1 stent. You start with provisional, either stenting to crossover from the left main into the LAD or from the left main into the circ, depends which disease is worse. And then after kissing, you make decision whether or not you need a second stent. And provisional strategy gives you broad variety of options. You can use T-stenting, TAP stenting, or culotte stenting. Depends which one you are the most familiar with. And with use of imaging, 12-month clinical outcome is not different for provisional versus two-stent strategy. To directly answer your question, there is no study specifically contemporary comparing provisional versus two-stent strategy for the left main. So we cannot say culotte is worse than DK Crush. That study was performed in DK Crush 3, I think, several years ago, but with different strategy of provisional. So it's not contemporary way with POT and mandatory final kissing that we recommend today.
We have some more time for the discussion. If you have any questions, you can.
Please.
Thank you, Professor Stankovic, for that wonderful presentation. I would just like to ask you whether you can give us some tips, because recently we had a case where we did a provincial stenting, we did a tap from left main to LCX, and there was a fairly big angulation with the LAD, and we were actually struggling to pass the second stent. We tried extra body wire technique, we tried the anchor balloon, and dilating the struts also with up to a 3O high pressure balloon. Is there any advice that you can give us in that situation?
Yeah, thank you for that question. This is the pitfall of provisional T or provisional TAP. And in case of excessive protrusion of the side branch stent into the main vessel, what we recommend is to do image-guided either conversion to culotte, so you rewire through the struts, through the lumen, and oppose stent completely inside the proximal main vessel with sequential final kissing balloon inflation, so it becomes culotte, or you simply cross through the struts of protruding stents, crush everything, and then you finish procedure with crush stenting. So these are two different options. One is to be careful and use imaging to make sure that you cross with the wire into the protruding stent and then turn close to carina into the main vessel and convert this to mini culotte. Or if that is not possible, you simply convert by crossing through the stent and crushing everything into the main vessel. You convert this protrusion of T or TAP into crush stenting, internal crush inside the main vessel. These are two options that we recommend.
Thank you, sir. And for the kissing, do you always recommend 2 non-compliant balloons or 2 compliant balloons?
For the kissing, for the kissing in provisional, we recommend non-compliant balloon mainly for the side branch. With non-compliant balloon, you can control diameter according to pressure that you are using. If you increase the pressure, you will still keep diameter close to predicted one, decreasing therefore the risk of dissection of the ostium of the side branch. For the main vessel, you are inside the stent, and we don't insist on using a non-compliant balloon. For the main vessel, you can also use semi-compliant balloon.
When we are dilating the side branch, should we always go to 1-to-1 size with the balloon for the same size?
Yes. Yes. We try not to oversize, because by oversizing you increase against the risk of dissecting the side branch. But what is more important for dilating the side branch is to use short non-compliant balloon with minimal protrusion inside the ostium of the side branch. It's very important for kissing to make sure that you cross the most distal strut and then to enter just few millimeters inside, because by inflating balloon, you don't want to traumatize the tissue of the ostium of the side branch. Kissing has two purposes. One is to remove the metal from the ostium of the side branch and scaffold partially the ostium, the roof of the side branch. And in the same time, kissing has the advantage that two balloons inflated simultaneously position carina in the center of the flow. Having carina in the center provides, according to CMD studies, computational flow dynamic studies, optimal flow pattern after stenting of the main branch. In that case, kissing optimally expands stent in the proximal part of the main vessel plus positions carina in the center. We should not oversize and we should not go deep inside, because in both cases we increase the risk of traumatizing the ostium, which increases the chance for using second stent.
So can you just elaborate on what pressures we should go to? When we
Yes, for predilatations, you can go even to higher pressures depending on the plaque composition. If plaque is soft, you don't need high pressures also for predilatation of the side branch. However, you do sequentially high pressure inflations in direction of side branch and main branch, but for final kissing, you go to moderate pressures, 6, 8, 10. You don't need high pressure for kissing. Most of the removal of metal is done by individual separate inflations. Kissing has the main purpose that with proximal overlapping part of two balloons, you optimally expand stent in the proximal part and you position carina in the center. So you, more importantly than the pressure, is to keep both balloons inflated, if possible, for 20 to 30 seconds. With longer inflation time, you achieve less elastic recoil of the metallic stent. It's very important to keep balloons 30 seconds, either with one inflation or 2 or 3 shorter inflations. For example, in left main, you cannot keep kissing balloons inflated for 30 seconds, but you can do 3 times 10-second inflation, and 3 times 10-second inflation provides the same result as at once 30-second, one prolonged inflation.
Thank you, sir.
Thank you for the answering our questions, and it was excellent lecture. We will thank on behalf of Sri Lanka College of Cardiology. Thank you.
Thank you. I wish you a successful meeting, and I'm looking forward to seeing you soon. Bye-bye. Have a good day and successful meeting.
Moving on to something that we don't see often, but nonetheless very important in the management of heart failure. It's all about implanting cardiac resynchronization therapy devices. So this is a session on challenging CRT implantation that will be presented by Dr. Mevan Wijetunga and Dr. Rohan Gunawardana, consultant cardiac electrophysiologist. The session will be chaired by senior consultant cardiac electrophysiologist Dr. Asanga Dunuvila, Dr. Suresh Kotegoda, and Dr. Susita Amarasinghe.
Good afternoon, ladies and gentlemen. Welcome to the next plenary on challenging CRT implantation. It gives me great pleasure to introduce one of my mentors, Dr. Rohan Gunawardana, consultant cardiac electrophysiologist at National Hospital, Colombo. He's also a device specialist, and he is the one who pioneered atrial pacing and right ventricular septal pacing. His special interests are pediatric pacing, arrhythmias in children, and his pet topic is syncope. He is a past president of Sri Lanka Heart Association and has been a country representative for the Asia Pacific Heart Rhythm Society. Over to you, sir.
Good afternoon. So we are moving away from coronary artery disease and stents and balloons, etc., to something slightly different. But as was mentioned by the speaker earlier, it's a very important part of treatment for heart failure, which has now become very much part and parcel of the therapies that are available. Now, I'm sure that every one of you here have heard about CRTs, cardiac resignal therapy, which we call CRTs in short. And we know that it has been around for more than 25 years now, and there's no question about the benefit. It has a definite benefit when it comes to morbidity and mortality, which is shown by various large studies, which I'm not going to go into. Just to remind you about the fact that not all patients with heart failure will actually benefit from CRT. That's an important point, because sometimes we get referrals with every patient with heart failure thinking that it might benefit. So it's important to look at particularly this class 1 indications. So whereas all of them should have an ejection fraction less than 35%, and the NYHA class should be 2 or more, 2 or 3. What is very important is that the QRS duration is very important, and here you can see that at least the QRS duration should be more than 120 milliseconds, preferably more than 150 milliseconds. And also studies have shown that it is those patients who have left bundle branch block who will eventually benefit most. So in our setting, where we are resource poor setting, this class 1 indication patients are the ones that we try to implant. That's the important point. Now, essentially, CRT device is a triple chamber pacemaker. So all of you know about dual chamber pacemakers, and I'm sure most of you have implanted dual chamber pacemakers as well. So additional to the two leads that we put in the dual chamber pacemaker, which is in the right atrium, right ventricle, we put a lead to pace the left ventricle. Now, access in a standard dual chamber pacemaker, access to get the leads is usually through a subclavian vein puncture or a axillary vein puncture, or maybe even a cephalic vein cut down. And we introduce the leads right into the cavity, the chambers of interest, that's the left, right atrium and the right ventricle. But we can't obviously puncture the subclavian artery for various reasons. Obviously, because bleeding is an issue. Neither can we put a lead through the aortic valve into the left ventricle, because the high pressure system and the risk of thromboembolism is extremely high. So the way we get the lead into the left to pace the left ventricle is to put it through the coronary sinus, which is the vein draining the heart, and into a branch of the coronary sinus. So therefore, actually, the left ventricle lead is actually sitting on top of the heart. So it's an epicardial lead, essentially, and pacing the ventricle epicardially. Right? Now, there are various steps in implanting a CRT device, and obviously the most difficult part is implanting the left ventricle lead. Now, there are certain hurdles that we have to cross. First is getting coronary sinus access. Now, we know that the coronary sinus is placed in the infraposterior position in the right atrium, just above the tricuspid valve. Very often we find that because of the heart, these patients with heart failure, the hearts are dilated. This whole the os of the coronary sinus is very distorted. It's not where it should be. Also, we know that there are about 25% of patients actually have valves across the coronary sinus, making it difficult to access. And remember that we are trying to access this completely blindly. So how do we set about this? The very fact that companies, now this is just one company, have so many different curved sheets which they provide for us to access means that it's not an easy matter at all. If we have all these sheets, maybe we can actually access the coronary sinus. But as usual in Sri Lanka, we get only one, the top one, that's all we get. And frankly, to tell the truth, I had never ever been able to access the coronary sinus with a sheet alone. So we had to use various other techniques to do that. Since we are electrophysiologists, one of the things that we tend to do is we put our EP catheters into the coronary sinus, and we are quite used to doing that, mainly from the femoral axis, but also from the superior axis, sometimes interjugular. So what we can do is sometimes we put the EP catheter into the coronary sinus and then telescope the LV lead over that so that we can get into the coronary sinus. This actually works in quite a lot of patients, maybe 60 to 70% of patients. We can actually do this, but sometimes we fail. In that situation, because we are sharing a lab with the cardiologists, we have access to all their sheets and catheters and things which we kind of borrow. Right? And essentially, we find various things. Now, for instance, one of my favorites is the AL1 or AL2, which can actually go into the coronary sinus. This was a case that we did recently. Very difficult. We just couldn't get in with the EP catheter. And with great difficulty, we were able to just get into the os of the coronary sinus, and we did a small contrast shot here, and we saw the beginning of the os. And then we were able to, if it's this place, yeah. So you would get a wire in, but you can see that it's a very difficult situation there, particularly because if you look at the orientation of this coronary sinus, it goes that way and then turns back on itself. So getting into this coronary sinus was very difficult, but we managed to push the wire in, and over the wire, we actually was able to put in our LV sheath. Sometimes even these methods fail, and we have to use other methods. One is that we can do a coronary angiogram and look at the follow-through and see where the actual, when the follow-through comes and the contrast drains back into the atrium, right atrium, you can see where the beginning of the os is, and sometimes that helps us to guide us to place the LV sheath. Right. So, but there are other methods as well. So in more complex situations, you have to do various other methods as well, and this can take a long time. So getting into the coronary sinus is the first hurdle that we have, and sometimes it is the biggest hurdle that we have. Once there, we have to have a suitable vein to put our lead in. We can't just put it anywhere we like, because it's been shown that the best position for leads are in the posterolateral region of the left ventricle. That's where we have. So putting it anterior, for instance, may not be that beneficial. And if we don't have a vein in this region, then we are stuck sometimes because we just don't have access. Other problem is that sometimes these veins are very small or at very acute angles, and we find that it's difficult to guide our wires through this. Remember, another thing is that with cardiologists, you have all the advantage of being able to shoot contrast as you go on. So you can delineate, or you can see the vessels as you go on. But because we are dividing the venous system, we only get a chance of getting one shot initially, and then we have to remember that and then go and try to place the lead. And even once we do that, there are problem is that we might not capture the ventricle, which is what we want. Why? Because say for a patient with ischemic dilated cardiomyopathy, the only vein that branch patient might have is actually sitting on a fibrosed area, and therefore we just can't capture the ventricle. So that's another problem that we might have. So as you can see, there are many issues and many obstacles that we have in actually placing LV lead, which is the most important part of a CRT device. So basically, of course, remember that in straightforward cases, it can be done in less than 2 hours now. In fact, last week, our registrar, Dr. Vasidaran, did a CRT case from beginning to end for 1 hour and 45 minutes, and that was it. So it was fine. But some can go on and on for several hours, even 5 hours, and sometimes we fail even then. Right? It is complex, especially when the anatomy is distorted. But by using various innovative techniques, we can most of the time achieve a successful implant. So I'll stop there. I just want to introduce the CRTs for those who have either forgotten to brush it up. And I think I will ask Dr. Mewan Wijetunga to continue with to show some interesting cases that he has had.
It's while the slides are being changed.
Dr. Mewan Wijetunga is no stranger to Sri Lanka College of Cardiology. He'd been here several times before in a friendly capacity as well as official capacity to assist us and conduct various ECG workshops and many other practical workshops as well. He'd been he has now moved to North Dakota in a more professorial capacity, I would say, obtaining a directorship of cardiac arrhythmias in the Altruza Health System, as well as he is the governor-elect of American College of Cardiology for the North Dakota. I guess that puts a lot of pressure on you. And as always, whenever he comes, he delivers very interesting and educative lectures. So this time, I thank Mewan for accepting this, and I'll invite him to deliver his lecture.
Thank you so much. It's always an honor to be with colleagues and also follow the steps of Rohan, who pioneered the CRT. And so I've been involved with CRT, I would say theoretically at least 20 years or so, and in implant maybe 17 years or so. So saw the evolution, because one of my projects as a fellow was to find techniques to how to find coronary sinus, because it was not there. And but today we have tools that get us into implants very fast, but still have challenging cases. So when Dr. Gunawardhan asked me to talk about challenging cases, of course I don't keep a track of these challenging cases. So what I did was I asked one of my technicians to run a list through the computer for all the LV leads implanted for the years, couple of years, and she got me 2019, and I think she got me closer to 70 cases. So I have access to electronic medical records, so I went one at a time and see what were the cases we considered really challenging. And there were a few really challenging cases, but I'm thankful the absolute majority are pretty relatively straightforward. So I have a lot of movies to show. So this is a case of a patient who I inherited, and the patient already had a single chamber defibrillator implanted for primary prevention some years ago. Sorry, it keeps running without, So, and then he has this dual chamber, he has a single chamber defibrillator with a dual coil. You see that there are two coils, and that lead was a Medtronic, what we call a lead that had an issue, so somebody has implanted another lead. And so he has two leads, and he needed left ventricular lead, so that's why he was referred to me. So things have changed for this patient over the years. And the issue I had was this, and this could happen with any type of pacemaker, it doesn't have to be. Now I'm implanting the LV lead. And here in our world, there is this keeps jumping, yes. Right here, I see the occlusion of left subclavian vein as it crosses the first rib, and there are so many collaterals. And as you know, the veins are not very forgiving to poke through like CTOs. You can try, but there was not even a trickle of blood going on. There's so many collaterals. Sometimes you can anticipate that by looking at the patient's chest, you see venous engorgement externally on that side. But when you see this, it gives us time to pause what to do. Options would be, in my mind, I am open for any suggestions, and try to be aggressive and try to open up the vein, but it's like opening up a CTO, and that's one option. But if I had a little trickle going through, I would have dared even put a balloon through that, but this was not a case. And then the other thing is to forget about this side, implant it on the left side and tunnel it across. That could be possible, put a lead on the left and across, but that's a little painful depending on the patient's body size, and it can be a lead just going over the sternum to the other side. But in this case, we decided to extract the lead, and so we used laser, and that helped us to not only remove this non-functioning lead, and there is a mortality risk with this procedure, but you have to do it very carefully under proper guidance with thoracic surgery backup, and fortunately we were able to get the lead out and then use the same access. So once you keep the access, because you have a laser sheath, and you keep the access, and then we get the LV lead like that. So we put a LV lead, and nowadays we have these leads with 4 poles, quadrupolar. You can have a bipolar also, but quadrupolar leads give us more poles to pace from. As Dr. Gunawardhan alluded to, sometimes capture of these, capture can be a problem. So the more poles you have, the better chances. Well, everything was fine until some time the lead fell. Lead didn't stay. So I had to go back another time and again pull that lead out and put it back in, and then it ended up being there. So that was a challenge with access. If you have any questions, I can stop, and otherwise I can move on. You can always interrupt me. Why didn't you do that? Or why didn't you do that? I'm open. This is, like a battle. So in the battle, you take decisions just as you do in interventional cardiology, and sometimes the wisdom comes afterwards. Yeah, you have a question? No. Okay, so that was the final position of the lead, and we try to place these leads as far away from each other so its heart is spaced from both sides so that the synchrony occurs. That's the premise of BIV pacing.
ICD looks really bad.
Really bent right there? Yeah. Well, it did. You mean like the way the shoe. So I try to give a shoe. My problem is maybe my patient population is quite obese, and when they stand up, the leads straighten. And so I try to give a little more like a shoe type of a thing rather than lead just hanging. And because this is supine and the diaphragm is pushing the heart up. Yeah, no, I agree. It can be. Yeah, it can be. Sometimes, yeah, most of the time it works. Yes. So this is another patient, and I call it again a difficult subclavian access. But again, this vein was open. But what happened is I put one wire, but when I tried to put the second wire, the vein has gone to spasm. You can see like a trickle going through. Now this is very painful. So I have access enough. And then, of course, you do like in the coronaries, you give nitroglycerine and based on the patient's blood pressure. But this vein kept going into spasm. I used a micropuncture needle, didn't work. So, and again, it looks open again after nitro, but then again. So I had to try another day because sometimes you just have to give up. You can't keep sticking and end up having massive hematoma that can cause in the chest. So another time I got the patient in, and that's again an access issue which you can address. So then once the patient came second time, of course we do the venogram. Now that's another problem. So once you enter the coronary sinus, you try to advance the sheath and get a venogram. And this is as opposed to coronary arteriogram. When you shoot dye in the coronaries, you go with the flow. It's antegrade, you go with the flow. But in the coronary venogram, it's actually retrograde you're looking into. So you have to really occlude with your balloon and push against the flow. And obviously, you don't want to overextend the balloon. A coronary sinus is less forgiving. Dissections or perforations do occur even. So you have to. So I do my first shot, I get a faint glimpse, and then I have carefully to double inflate the balloon to get adequate access and to the balloon. And then even here, I don't have a great idea where I need to go to. Again, just some faint ideas. And then I push it further, then again, so these are the challenges. So I had to, because until I had to gauge it a few times. So now I go a little further in, and then I get a total occlusion, and then I wait until retrograde filling occurs, and then I can see there are a couple of options. There's anterior lateral branches there, posterior lateral branches there. And the same image in the RAO view here, if I stop here, those who are not oriented, this RAO view, and this is like, if you follow my, sorry, my slides keep jumping. I think it's something the way I did it. So this is the sort of LAD path. We don't want to put it there. We don't want to put lead anteriorly. We have to go laterally in the RAO view. But this, if you come down here, you come to the apex. So you don't want to put the leads there. That's very easy to put a lead in the LAD, parallel to LAD. But then you have one lead on top of the septum, other lead in the RV. That's not BIV pacing. BIV pacing has to be this way. Not like on, not vertically, it has to be horizontally. So this one, finally, I put lead in the anterolateral branch, farther out, and then you can look at the LAO and you can be happy. That's the way you see the two leads are farther separated. Okay, so next challenging case was actually access the CS. Now here, my go-to way of calculating CS is using an external catheter, just the same way like Dr. Gunawardhan does, but I use usually AL1. And you go to the, with the AL1, you put a wire, so you have this catheter coming down. I usually implant LV lead after, as my third lead. I first put the ventricular RV and RA leads. So you cross the tricuspid valve, you pull back and you clock. So then hopefully it finds its way to coronary sinus. You cross the tricuspid valve. It's not exactly the same way you do a swan because you have to get to the atrium. And with the AL1, you clock and then it usually falls. It doesn't usually, in majority of cases, within 15 to 30 seconds, you are in the coronary sinus. When you are in there, the issue is coronary sinus may be going in that direction, the ostium is here, so you have to sort of play it to get in there, and then without hurting the coronary sinus, because if you are too aggressive, you end up causing a dissection or perforation. Dissection is more forgiving. You stain the coronary sinus, but unfortunately, once you stain it, you can't see it beyond. So then you are done for the day. If you perforate, obviously you end up having pericardial effusion. That you can monitor for the most part, and in real you need to go and tap, but because it's a venous system. But it can happen that you need to tap. That has happened. So in this case, we get to coronary sinus, get a venogram, and fortunately there are a few branches I can work on, and then ultimately the lead end up going into a posterolateral branch out there. So that's that case. So these are like access issues and things like that. Another problem that can happen is this. So this is not that bad, but the posterolateral branch, and the same branch can be in the RAO view, fairly acute. So if you really appreciate it, my catheter goes in that direction, but I need to go at least 90 degrees to go to that branch. It's the same branch. I'll play it again. Here, there. So if you put a lead in, it sort of gets directed up. Now I have to go that direction. So again, there are subselector catheters like this that helps us. And once you do that, you can send the lead through the subselector and gets ended up going to the lateral wall like that. So, but again, the issue is then once you put all that, you have to carefully get these sheaths out without pulling the lead back. And these things happen. You'd spend so much effort to put the lead in, and then once you pull the supportive sheaths out, the lead can get dislodged. So my staff usually say biventricular pacing is never done until I'm out of there, because it can cause trouble all throughout. Okay, so another interesting case I want to share with you is this. This is a patient I never succeeded. And this is a gentleman, older, had Epstein's anomaly and had tricuspid valve, some sort of reconstruction surgery. And life went by, and now he has ejection fraction 30-35% and heart failure. I really apologize, my slides keep getting advanced. It's, I think, the way, it's my mistake. But, and I tried to cannulate the coronary sinus in this patient, and went from up, tried the dual catheters. I used EP catheters, everything, and couldn't get. And in this case, just like Dr. Gunawardhan did, I even tried, I did the LAD shot and tried to wait for the liver phase or the follow-through. I see something getting here, and I thought that's a coronary sinus. It seemed to be draining, but I can't get in, and I don't understand. Of course, it's Epstein anomaly status post-surgery, and it's not the normal right atrium. So I gave up that day. And then I brought him back. I went on to even use what we call a 3D mapping of the 3D map. And I created the right atrial map through the EP equipment and see whether I can find coronary sinus. No, that one I couldn't. And I had to give up on that. I didn't want to bring him for the third time. But then I studied it. I was wondering whether this could be. This is a case report. If you look at it, this is the same similar patient who had Epstein anomaly and had a tricuspid valve surgery. But if you look at this, there is no, this is again, they did an arteriogram, but there is no real coronary sinus coming up. It stains a lot, but finally you started seeing towards the end of it, there's something here dilated. That's because if I play it again, there is a venous flow, but it doesn't flow into the right atrium. That's because, in Epstein anomaly, you have the apical shifting of the tricuspid valve, and during the reconstruction surgery, you get the valve pulled up here, and then when you do that, you may be impinging, the surgeon may be impinging on the coronary sinus ostium like this. So if this is the tricuspid valve, they may be putting a suture line right next to that or right like this. And in my case, probably this was like a tiny slit, the surgical suture line, and it doesn't help me to find it. So that patient never got a BIV. And there are other surgical options he ended up pursuing. And this may be my next to last case. This was also a challenging case I had that year. This was a relatively young gentleman with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy and sudden recurrent syncope, and the only surviving member of the family other than his mother because of hypertrophic cardiomyopathy. And he had a defibrillator implanted somewhere else on the left side and had an infection, and it was removed. So by the time he came to me, he had this device, a dual chamber defibrillator with an abandoned lead, and this was infected too. So, and then things have changed. He was probably in the burnout phase of hypertrophic cardiomyopathy. Now he had a big left bundle. He had undergone this myectomy surgery as well, so that contributed to the left bundle and heart failure. So we thought of, now this device is infected. We had to remove it anyway and then go for the BIV. So, but anyway, first of all, we had to remove the device. So I went and extracted the lead. It was tough because it's on the right side, and remove the entire system and let it heal. And once we are done, give him the time to heal, and got the infectious disease people to help me. And I brought him back to put a new device on the right side. And this is what I see on the right side. Sorry, I'll play this again. And the right side is occluded, right? It doesn't, there's no, it goes there and then finds collateralization. I can't go. And right side is occluded. And I tried the left side, and the same thing. Obviously, we knew the left side is occluded, but I was still hoping. So, what were the options? Both sides are occluded. A young person, strong history of, he needs at least defibrillator, let alone a BIV. Any thoughts? I thought I would put a device from the groin. How many times I've done it? Few, not many. And so I ended up putting a lead from the groin. And obviously you had to put the lead above the inguinal crease, because otherwise each time he's bent his leg, the lead will bend and break. So you have to mark the inguinal crease, but still, fortunately, a lot of obese people, crease is below the femoral vein, so you can enter and put a defibrillator lead in, and then he needs an atrial lead. Then I thought, your device is down here, heart is here, I will put an atrial lead also, a defibrillator lead, just in case if I need it. So put those two leads from the groin. Then I thought the easiest would be to do the LV lead, because we always, as Dr. Gunadhan said, we always get the coronary sinus from the groin when you do EP studies. And I get into the coronary sinus with the EP catheter, get stuck there. I can't push it. I try to curve this way, that way, but I can't. Then at some point I had to stop, because I can easily poke through it. So by this time, a lot of time has spent, and I was showering with radiation by that time, and you had to call it. So we stopped doing that. I tried different techniques, multiple ways, coming from top, I can't come from the top in this case because it's blocked. I go only part way to the coronary sinus, can't enter. See there, I'm in the CS, but I can't advance beyond that. So, and said, okay, we'll bring you back. But what happened was, so this is his way, we check, he has the CS, and you can see here, there is a runoff here, now when the LED is done, and you can see there is a coronary sinus, but maybe coming from a very unusual angle, like that. So, I told him we'll bring him back. I tried again, didn't work. Going on part ways, can't go further. So put the device from the groin like this, it's above here, and it goes down through the femoral vein and up. But what happened was, before I brought him back, he got that one infected too. And so I had to pull that out. And I think he probably has a propensity for infection. I think also, so I had to do, actually surprisingly, I had to use laser to extract it. So I extracted that and let it heal. And at that time, I decided, no, it's not my job to do it anymore. So he went to the Mayo Clinic and they implanted the lead epicardially. He doesn't follow up with me anymore, but I saw that. So he's that. And then we usually come across other problems like, these tortuosities and problems like that. But usually we end up navigating that pretty reasonably. But other problems like this one, look at that, pretty much like totally opposite direction of the flow, right? We are going up and we have to turn back. Sorry, my light. And in this case, I had to go like almost 180 degrees to come down here and then to navigate this siphon. You can put a wire through this, that's not the issue, but to get the lead tip to go through all that, it's very difficult. Sometimes you struggle. And there are tricks sometimes you can do, but these are the challenges with coronary veins. In this particular case, I had to put the lead in the anterolateral vein, and that saved my day. But that lead got dislodged. So what do? In this case, as an alternative, I put a lead on the His bundle level. In this patient, His bundle pacing is a new technique. I don't say it replaces BIV pacing, and now when you're pacing the His bundle, you can get a very narrow QRS, just like his native QRS. This is not the same patient, like I showed you, this is another patient. So that could be an alternative for LV pacing, but the studies are ongoing. Thank you.
Thank you, ma'am, for that interesting series. I'll just want to show you a couple of cases that we had recently. Again, challenging CRT implantations. Okay. So now, we know that some patients have what we call persistent left SVCs, and if you look at the kind of configurations, so these are normal situation, but you can have configuration like this where you have a connection between the left persistent and the right SVC, or it might only have a left persistent SVC, and that part actually ends up at the coronary sinus entering it's a large coronary sinus entering the right atrium. So recently we had a case, it's about a couple of months ago really, where we did a venogram on a patient who were hoping to do a CRT. And this is what we saw. So we find a left persistent SVC. There's no connection across to the right side at all. So we were wondering what to do in this situation. One thing, if it was a pacemaker, we have put pacemakers through the left SVC. It's not impossible, but we would have always gone to the right side, and that's probably the simplest thing to do. But here we were going to put a CRT, and then I was thinking that getting because the coronary sinus is so large, getting the LV lead into a coronary sinus branch might be as difficult from the right side as the left side, and we thought we will try to see what we can do with what we had. So these are long guide which we put into the coronary sinus to the left SVC. You can see it's going right into the right atrium. Unfortunately, we have some very beautiful pictures of this, but our radiographer had unfortunately deleted all this very sorry, but so I have just made some pictures. They're not very great, but this is how we did. So what we did was, so we had to find the branches, and unlike a situation where we can occlude the coronary sinus and then give a venogram, we can't do that simply because there's no way we can do that. And anyway, now in NHSL we are completely run out of balloons, so we can no longer actually do a venogram using a balloon occlusion. So what I did was, and again, one of the advantages of sharing a lab with cardiology is that we have all kinds of catheters. So I looked around and found this sheath, which I don't know what it was actually, but anyway, the shape looked good to me. So I put this sheath down here and just pull, and then gave contrast while pulling back. And we found two branches, one which was quite near the corneas, another one slightly beyond. So then what we did was, we were able to get into that with the cornea sheath, and then we telescoped our LV sheath onto that and engaged the beginning of that branch. We were able to get in maybe a few millimeters. But every time we tried to put the lead and push it in, this whole thing came out. Then when we were doing this, we suddenly realized that the wire that we put, this is a PCI wire, went into the branch and came out of a more proximal branch and was now hanging around in the subclavian vein. So then that's we thought we can do something there. And again, the advantage of being in a cardiac cardiac lab, which cardiac facility is that, you know, the cardiologists are very good at losing things in the vascular system, and therefore they have to get these things out, and there are a whole lot of armaments, including various snares. So in that situation, what we did was we took a snare. This was actually a gooseneck snare, and we were able to catch this end of that wire with the gooseneck snare and then hold it there. So we are creating a railroad, and we were able to push our lead through that and eventually get a very nice position. So these kind of things are very unusual, but you can do these things if you kind of have a bit of trouble, and but you have the equipment that we can sometimes use. So that was a very interesting case. The second case I want to show is, as Mevan said, sometimes we have we have branches, lot of branches, but we don't have a proper branch. Now here is a patient, again, we did this recent case where we had this coronary sinus, big coronary sinus, lot of small branches, but they look tiny. We were able to wire down one branch, and then this is the branch that we wired down, and we were able to send our PCI wire right around, and we created a lot of support, but we just couldn't send the lead in because it was the vein itself was much too tight. So then what we wondered what to do, there are simply no other branches that were suitable, and then we thought we'll try to get into this, the middle cardiac vein here. But you see, it's not acute, it's an acute angle, it's going back on itself. So again, we found, and this is where I enlarged it, and we found this catheter AR1, which we are able to now hook it here and send a wire across it, and eventually we were able to straighten it out with the sheath, and we were able to give a venogram there. You can see this is the original branch that we tried to go through, which we simply could not access. So we were able to get there and eventually place a vein, place our lead here. Initially I was a bit disappointed. I thought this lead position not very good at all. But when we looked at the ECG, we can see that it has actually a very nice result. The broad complex no longer there, it's a narrow complex, and the very negative QRS in the lead one shows that we are placing the left ventricle quite well. Okay, so those are the cases that we want to present, and if there are questions, we are all ready to answer questions.
If any questions, anyone suggestions to anything we have done? Yeah.
Thank you, Mevan, for that wonderful presentation. It's always a pleasure to listen to your lovely talks, very informative. And I mean, it's so nice to see you doing all these heroic things in a very high litigative environment. I think you need a lot of guts to do these sort of things and a lot of experience as well. So I'm quite fascinated by that case where the SVC was occluded, or the subclavian. What is the cause of that occlusion? It is just thrombotic, or?
Yeah, so I think once you have any type of a device, any lead, I don't know, it's a substantial, I don't know, I would say 5% of patients end up having some sort of fibrotic occlusions. And for the patient, often it's not a problem because the veins always find collaterals. It may look a little bad on the skin. On that side, you see venous engorgement. Very rarely you end up having like a edematous arm because of that occlusion. So you almost always find it if you need to re-access the vein. And that, that's the issue. And so I think it's fibrotic. The thrombotic occlusions usually occurs immediately after implants. I have seen them like a local development of DVT type of thing, but those patients usually end up having edema and some swelling since acute. These are like chronic, most of them are, so there's plenty of time for the collaterals to develop. I think it's fibrotic. And then why people develop fibrotic as opposed to the others? Do we traumatize the veins more when during implant, or these people have an inherent way of developing fibrosis? We don't know. What is it? Yeah.
So it's also fascinating to see you navigate the coronary sinus and with all the implications of damaging the coronary sinus. We've heard that if you get acute thrombotic occlusion of the coronary sinus, you get acute myocardial infarction, one of the rarer causes. Have you come across any in your practice?
Fortunately, no.
Right.
But I have seen, few dissections and couple of perforations. Fortunately, I haven't seen, there was a time, I must tell you, I think when I was navigating a coronary wire, I ended up leaving a small piece of wire in the coronary sinus. It happened at, distal part of the BMW or something like that. But hopefully, it ended up going to the lung in the worst case and nothing happened. But no, that did not result in a thrombus. No, not even long term. Because you don't know, you may have local thrombi, but no, fortunately not. While there was a time, once I asked my interventional colleague to come and help me, and he put a peripheral stent in, because coronary, I think usual coronary stents are too small, to help me to navigate a branch vein.
Yeah, it's good. It's refreshing to see electrophysiologists using guide wires and guiding catheters. But just to your point about coronary sinus, so we've been doing lots of work with counter pulsation balloons in the coronary sinus with the Pixo device in patients with acute myocardial infarction. So whereas previously I didn't even know where the coronary sinus was, suddenly in the last 3 years I've had to learn. And exactly the point that you've made, I've now realized they come off at different angles, some come off in different areas. So we've asked the company, and they've come up with a steerable guiding catheter. I don't know if you have that here, but for that example that you gave where the coronary sinus coming off, which seems to be posteriorly, we use this Oscor guiding catheters, where we put the steerable catheter in, and then there is a knob that you can twist in all directions, 360 degrees. And we also use the injection of the LAD late to follow through. And it has allowed us to pass guide wires and 032 wires into the coronary sinus. And then we take this counter pulsation balloon into the coronary sinus, and we leave the balloon there for around 45 minutes. And to your point, so we've had cases of coronary sinus dissection, but we've never seen a case of thrombosis.
No.
And I just wonder whether that's because of the size of the artery, and actually the flow is quite vigorous. Yeah. So I think even if you get a dissection, as such, in 3, nearly 4 years of doing these, we've never seen a coronary sinus occlusion.
Thank you. That was illuminating for me too. I recall a long time ago when I first started doing research on how to find coronary sinus, that was early 2000s. I realized there is initial interest in among the general cardiology at that time, interventional cardiology, about the coronary sinus for the retrograde perfusion techniques they were thinking, and I think that faded away as a part of treatment of ischemia. But what I'm hearing, I'm learning again, this could be, is it for the refractory ischemia type of?
ST elevation myocardial infarction.
Acute.
And it's the rationale is that counter pulsation increases the flow of all the inflammatory materials and microthrombi in the capillaries at the time of infarct. So we've seen that it reduces no reflow, this counter pulsation. And the first phase study that we've done has shown that it reduces infarct size based on MRI scans at 5 days. So this second study that we've just completed, which is a randomized control study, has randomized patients to counter pulsation versus standard of care, and we're looking at clinical outcomes now. So that we've completed the study, the data should come out in 2023.
Oh, look forward to.
Is it only counter pulsation or with primary PCI? Primary PCI with counter pulsation. Oh, yeah, no, you've got to do the primary PCI.
Yeah, obviously. Yeah. You can enlighten me. For LV lead implantation, we don't have steerable sheets. So, but we do have steerable EP catheters. So sometimes we can use that to guide. We do have, there's one or two steerable sheets I use for ablations but those are not really useful for the LV lead implant. Yeah. That might come to the EP side too one of these days and look forward to. The other thing is when you have a dissection of the coronary sinus, if you're lucky, you can probably bypass it and still implant the lead, but often it muddies the picture when it all stained out that area, so you don't know where the distal part of the vessel is, and I try not to be heroic on those cases. And earliest as 2 weeks later you can reimplant because that dissection resolves. That's the earliest, and maybe you wait 4 weeks, and all 100% cases you can go back and do it. Yeah.
For his bundle pacing, and therefore I'm sure that we can have for coronary sinus. Is it Agilis you're talking about, or is something else?
It's called OSCO.
All right, okay. Yeah. So even the Agilis is a steerable sheet that we use for EP, which is also a very, very good sheet. So it's always possible, but I think we are able to get to the coronary sinus most often without all these things. So we are lucky that we are able to manage with other things that we have.
Yeah, exactly. There is another sheet called Visigo. You can even see it through the 3D mapping, but we don't use it for CS. Thank you. Any other questions?
Sorry.
Yeah, go ahead.
I think we have come to the limit of our allocated time. So, any other burning questions? Yeah. So, in the absence of other questions, I would like to thank Dr. Mevan Wijetunga and Dr. Rohan Gunawardena for that very informative and excellent discussion on practical implantation of CRT. On behalf of the College of Cardiology, we thank you. Thank you.
A big thank you to the electrophysiology team again for enlightening us on some of the very interesting aspects of CRT implantation and about the coronary sinus and its access. So moving on, coming back to coronary artery disease, the next session is on management of STEMI. The original speaker for the session was supposed to be Professor Dariusz Dudek, an eminent cardiologist from Poland. Unfortunately, I think we are having connectivity issues in connecting Professor Dudek, in which case a senior consultant cardiologist from Colombo, Dr. W. Shantaraj will take over. May I invite Dr. W. Shantaraj to chair the session in any case. If we can get through to Professor Dudek, we will connect him. If not, Dr. Shantaraj will then take over. The other panelists will be consultant cardiologist Dr. Chandrika Ponnamperuma and consultant cardiologist Dr. Sunet Karunaratne and Dr. S. Vinodan.
I had to do it as a bailout thing here, management of STEMI, because they couldn't contact the, because there is some technical problem. You couldn't, no. I don't know whether you can connect it in between. By that, I'll give my lecture. If they can connect, I'll stop my lecture and give this. The lesson learned from I'm going to talk about the management of STEMI. The lesson learned about STEMI care over the last 15 years are one size of STEMI treatment does not fit all. That is, each and every STEMI you face in clinical practice are different, right? That is the only condition. It gives you some satisfaction. When you open up the artery, you are very happy. But in the meantime, each and every STEMI, it can be a surprise. And also you can plan, you can't plan. Now, if it is a routine angioplasty, you can plan and go in. But in a STEMI patient, you cannot plan. The fibrinolytic dose reduction is prudent in the elderly. The new guidelines suggest that you should give half dose for people more than 75 years. And some reperfusion is better than prolonged delays from primary percutaneous interventions, especially in patient presenting early, which is large territory at risk. So if you have no facility of doing a primary PCI, if a patient presents within 3 hours, so very early in myocardial infarction, the thrombolytic therapy is equally good as doing primary PCI. We must overcome under or delayed treatment, even in the large urban areas, well populated with ample PCI facilities, an unexpected delay to the PCI can open. Example is a Colombo, because you can get an unexpected delay, but don't deprive the patient of a thrombolytic therapy because of you are going to do a PCI. The thrombolytic therapy is available. If the patient presents within 3 hours of chest pain, just give the thrombolytic therapy. To be relevant, door to needle time or door to balloon time must be interpreted as a context of total ischemic time. The pre-hospital diagnosis and treatment by paramedics can save 1 hour from the total ischemic time and save myocardium. This is what Sri Lanka College of Cardiology and the ambulance service are trying to do. We are trying to give the ECG machines and get the patient quickly. I think how far it is progress, we don't know, but I think we should go on with that. So what the guideline says is if the patient presents very early, within 3 hours, the primary PCI and the fibrinolytic therapy carries the same level of recommendation. But when the time goes off, the effectiveness of thrombolytic therapy goes off. So then the primary PCI become a choice of treatment. And up to 48 hours, you can do primary PCI. If they are symptomatic, even if they are not symptomatic, also you can consider PCI. But after 48 hours, if the patient is not symptomatic and then there is no, if the artery is completely blocked, there is no indication to actually open up that artery. So regarding a little bit of fibrinolytic therapy, that as I told you, within 3 hours, it is equally effective as primary PCI. And when you are choosing an agent, you should choose a fibrin-specific agent like tenecteplase. And half the dose is suggested for patients over 75 years. I will just skip the antiplatelet therapy because all of us know. And anticoagulation is a must with the fibrinolytic therapy, especially the tenecteplase. But if you are using streptokinase, the anticoagulant should be started after 24 hours. And once the fibrinolysis is done, you must consider transferring the patient to a PCI center to do a angiogram and possible PCI. The emergency angiography for PCI, if indicated, is recommended in patient with heart failure or shock. Despite thrombolytic therapy, if the patient is in heart failure or shock, then you have to go and do a angiogram and PCI. Rescue PCI is indicated immediately when fibrinolysis have failed. So how do you know that? If there is less than 50% reduction in the ST segment resolution, or at the time of the presence of hemodynamic electrical instability or worsening ischemia. So if there is indication that your thrombolytic therapy has not worked, then the primary PCI should be performed. The angiography and PCI for the infarct-related artery, if indicated, is recommended between 2 to 24 hours after successful fibrinolysis. But in our context, I don't know whether it's possible, but the recommended time in ideal setup in the European guidelines is that. The emergency angiography and PCI, if needed, is indicated in the case of recurrent ischemia or evidence of reocclusion after initial successful fibrinolysis. So this is the one, again, I have to emphasize that late presentation is STEMI. You can consider primary PCI, but there is no support for the fibrinolytic therapy. And you can consider primary PCI in asymptomatic stable patients up to 48 hours. But after 48 hours, even asymptomatic stable patient, PCI is not indicated. So this is the paper which was recently published about percutaneous myocardial revascularization in late presenting patients with STEMI. You can see up to 48 hours, if you can revascularize these patients, there is reduction of risk reduction of about 30% you can expect. So up to 30 or 48 hours, even if they are asymptomatic, you can consider revascularization. This is a old trial. That's the reason. Based on this trial only, the recommendation for not to do any PCI after 48 hours in a totally occluded artery was recommended. That you can see, if you open up that artery after 48 hours in a stable patient with totally occluded artery, then of course you can see the incidence of non-fatal reinfarctions and fatal and non-fatal reinfarctions are high in patients who have opened up the artery. So that in a totally occluded artery more than 48 hours, you should not do PCI if they are asymptomatic and if they are hemodynamically stable. So this demonstrates this flow chart demonstrates what you should do. That is, if you encounter the STEMI, then if there are symptoms of onset is less than 12 hours. PCI feasible, yes, go ahead and PCI. No, large area of myocardium at risk, you can do, send for bypass. Well, symptoms of onset is more than 12 hours. Cardiogenic shock or heart failure, PCI feasible, you can do primary PCI. If it is not feasible, then of course you have to consider the CABG according to the American guidelines. And ongoing ischemia, heart failure, or electrical instability, primary PCI is indicated even over more than 12 hours. Symptoms of onset is within 12 to 24 hours, then you can again consider PCI. And totally occluded infarct-related artery, more than 24 hours, without any symptoms or ischemia, then there is no indication to open up that artery according to American guidelines. But the recent study shows up to 48 hours, you can open up the artery, right? And procedural aspect, that is routine use of thrombus aspiration is now not recommended because once you do an angiogram, you have to assess the thrombus burden. The thrombus burden is very high, you can consider using an aspiration device, but if the thrombus burden is not high, you should not use routine thrombus aspiration. Routine use of deferred stenting is also not recommended. That is, just opening up the artery and coming back to do a stent later is not recommended unless your thrombus burden is high. If you think that if implanting a stent is going to cause more thrombus, then that situation you can defer the stenting. What about the non-infarct related arteries? Now, whenever you do primary PCI, you can see other vessels are also involved. How do you tackle that situation? Routine revascularization of a non-infarct related lesion should be considered in STEMI patients with multivessel disease before hospital discharge. That's what the current guideline says. If you see significant lesions in the non-infarct related artery before the patient's discharge, you have to consider revascularize them. If the patient is with a cardiogenic shock, it is the latest guideline which was available was 2017, but now we know if the patient with the culprit shock trial, that is, if the patient has cardiogenic shock, you should open up only the culprit artery and you should not open up the other arteries. I will come back to that later. CABG should be considered in patients with ongoing ischemia and large area of the deputized myocardium if PCI of infarct-related artery cannot be performed. Okay. 2B3A inhibitors should be considered for bailout if there is evidence of no reflow or thrombotic complication. Again, 2B3A inhibitor use is not routinely recommended in a patient when you are doing PCI. But if you think the thrombus burden is high, or after implanting you see thrombus in the vessel, then of course you can consider giving 2B3A inhibitors in addition to other anticoagulation and antithrombotic therapies. Anticoagulation is recommended for all the patients in addition to antiplatelet therapy during PCI. But after PCI, what's the recommendation? The guidelines usually don't recommend. I will come back to that later. Again, you can use unfractionated heparin or enoxaparin during procedure, and fondaparinux should not be used because it causes catheter thrombosis. Now about the non-culprit lesions, there are several trials which have been done, like this PRAMI trial, CV, LPTRT trial, DYNAMI trial, and all these trials have shown that if you revascularize the non-culprit artery before the hospital discharge, the prognosis is better. But the culprit shock trial, which the last trial you see in the thing, you can see, if you revascularize the non-culprit artery, then that is bad because it's a culprit artery only revascularization. The risk is only 45.9%, and if you revascularize the the non-culprit arteries also, then it's become 55.5%. On that, and that finding only now, the shock patient, you should not open up the non-culprit arteries during the procedure. The opening up the non-culprit arteries during the procedure depend on several factors, because now you can do it when you are doing the primary PCI, or you can stage it and do it. So what are the factors which affect the decision of that? That is the advanced age. If they are very old age, they don't try to do it in the same sitting. You can bring them back and do it later. A poorly controlled diabetes mellitus, try to do only the culprit artery and come out. Advanced chronic kidney disease, if they are already diagnosed, don't try to do other vessels as well. Late presentation, because late presentation ST elevation MI, they are more thrombotic. Even doing primary PCI is a bit difficult in this category of patients because they are more thrombotic, they are more prone to get no reflow, and those complications are more. Because of that, I think you should not do the other vessels if they are late presented MIs. High syntax score, then again, you should not touch the non-culprit vessels. You have to consider the CABG later once the patient recover from the acute MI. So the baseline characteristics, coronary angiography, and also if you have the facility to do intracoronary imaging and physiology, and that all will help in revascularizing or making a decision of revascularization of a non-culprit artery in a setting of STEMI. So the revascularization of the non-culprit artery by this flow chart, you can see the STEMI with successful PCI of infarct-related artery on the top, you can see. Then you have to see whether the patient is in shock or not. If the patient is not in shock, lower risk patients, lower risk of other lower risk lesion from the other arteries, you can do a complete revascularization at once. But the patient is in shock, then you should routine revascularization of non-culprit artery is not indicated. So defer the routine non-culprit artery revascularization. Non-culprit artery supplying large area of myocardium at risk and absence of multiple comorbidities. If it is yes, complete revascularization is achievable, then you can go and do the complete revascularization. If it is not, then of course you can defer and you can consider sending the patient to CABG later. So what about using the FFR and other assisted physiological measurement in revascularization of the non-culprit arteries in STEMI. So there is a study. This study was performed on FFR versus angiography guided revascularization. This study shows there is not much of difference between the angiographically defined non-culprit revascularization and an FFR or IVAS guided revascularization. So you can go by the angiographic guided revascularization well, because in our setup, I think it is promising. So the complete revascularization is recommended in patients presenting with an acute, say, ST segment elevation myocardial infarction without shock. In individual who presents with cardiogenic shock during an acute STEMI, revascularization of the culprit vessel only is recommended. The fractional flow reserve or optical coherence tomography or CT evaluation on non-culprit vessel can be guide the revascularization strategy, but it is not essential. European guidelines now recommends that routine revascularization of non-culprit vessel should be done in patient with SME with a multivessel disease before hospital discharge. The American recommends that you can do it in the same setting if the lesions are suitable and the patient is not in high risk. Okay, in the interest of time, I will skip this slide because antiplatelet therapy, we all know. What about the future of the STEMI? Now, I told you in each and every STEMI are not unique. Why is this? Because once the coronary occlusion occurs, and the outcome of STEMI, whether this patient is going to recover completely or if he is going to have problems in future, is depend on several factors. That is, you can establish the reperfusion. That is easy to do because we all know if the patient comes very early, put the wire, it will open up the artery and you put the stent. But the outcome, some patients we see after 24 hours, ejection fraction become 25%. Some patients, the ejection fractions preserved. So why it has happened? Because there are several factors involved in this. That is, one is the microvascular obstruction. That is because it is mainly in the late comers, but in the early comers also it can come because when you balloon and do procedure, the clots and other things can go and cause microvascular obstruction. But this doesn't happen in everybody. So there are several explanations why it doesn't happen. But other than that, it can cause injury. Injury can be at muscular level or endothelial levels, and coronary remodeling can happen. So these, and inflammation and thrombosis, all these can contribute to the microvascular health. Ultimately, although you open up the epicardial artery, the outcome depends on your microvascular perfusion. That is important. So the mechanism of microvascular occlusion of myocardial infarction, it is several. That is, there is individual susceptibility like genetic, acute hyperglycemia, diabetes, hypercholesterolemia, lack of preconditioning, all can cause microvascular obstruction. Pre-existing endothelial dysfunction, like some people, they get microvascular angina without any obstruction in the vessel. If those people get MI, they are more prone to get microvascular obstruction. Other thing is mechanical, like obstructive emboli of microcirculation, release of pro-inflammatory cytokinins, formation of platelet and neutrophil aggregation, all can cause microvascular problems. And ischemia and reperfusion. Actually, reperfusion itself can cause microvascular dysfunction and myocardial injury. So all these can contribute. I think when you are doing a primary PCI, you have to consider all those things, not only in the epicardial vessel, what is going to happen in the microvascular circulation. So you can see the study shows that the left ventricular reduction in the mass, damage, that is mentioned in the highest percentage of left ventricular mag. The excellent prognosis is with those who have microvascular dysfunction without microvascular problems and reduce the damage for the left ventricle. The worst prognosis is in patients who have microvascular obstruction present and with the left ventricular mass damage more than 25%. So that you can see, and it is confounded by, you can see there are several confounding factors. You can measure whether these things are involved in the prognosis of myocardial infarction. One thing which stand out there is a microvascular obstruction with a p-value of 0.01, you can see. And little bit about antithrombotic studies after primary PCI. Now, there are a lot of doubts whether you have to give the heparin after the procedure. It is, give me 2 minutes, I'll finish. And after the procedure. So in the cath lab, no question, you have to give anticoagulation and anticoagulation. After finishing the procedure, do we have to give enoxaparin subcutaneously for 24 hours or 48 hours? Because you can see the thrombotic risk is very high within that 24-hour period. So will that help? Or post-discharge period, there were several studies. You have to give anti-platelet agents. With that, some people, they give rivaroxaban and those things you can see. Some people's prescription you can see. So what are the idea about that? And you can see the post-procedural anticoagulation in patient with acute ST segment elevation MI undergoing primary PCI, coronary intervention. This is a study published in the American Journal of Cardiology in February 2020. You can see it is a Chinese study that showed that if you give post-PCI anticoagulation, actually those patients had less MACE during follow-up period. But this study was actually, there were several flaws in that study according to some of the editorial comments, but there was a study like that. And but in our practice, I think you have to see who is at high risk. If you see thrombus after doing primary PCI in the vessel, I think it's better to give enoxaparin for 48 hours or 24 hours. That may be a good practice. This is another study, reduction of stent thrombosis in patients with acute coronary syndrome treated with rivaroxaban. And you can see in that study, those who have been treated with rivaroxaban has less thrombosis, but in a particular group, that is those who had more than 2 vascular beds involved, like the vascular, what we call is a very high risk patient to get vascular event. In that sort of a patient, I think if you have, especially if you have implanted more than several stents, that sort of a patient, I think adding rivaroxaban 2.5 milligram twice daily may be helpful in the long run according to these studies. But if they have no high risk features, you can see the benefits are not that significant. So that's the reason the guidelines says that is post-PCI, more than 1 year, multi-vessel disease, you can use rivaroxaban in some of the patients, but not with the patients, simple patients. Okay, with that I will close, I will stop my lecture. Thank you.
Thank you very much, sir, for that excellent, very informative lecture, and also to chipping in at the last moment to fill in the gap. If there are any questions, I'm sure Dr. Shantaraj will be very happy to answer.
Just to make a small comment, I think Dr. Shantaraj did an excellent lecture on primary PCI and acute STEMI management interventionally. The sad thing in this country is that according to the national audit project we did, similar to the MINAP in UK, where 98% got primary PCI for STEMI, in Sri Lanka, it's only 68%. It's only 6%, as opposed to 99% in UK. So still about 68% get thrombolysis, as you mentioned earlier. So that's a good option that we follow in this country. So this is, I am referring to the 2017 Sri Lanka, it's called the ACSLAP, Acute Coronary Sri Lanka Audit Project, in the same lines as MINAP, WHO sponsored, entire country, Health Ministry sponsored, published in the BMJ with very good reviews. So ACSLAP also showed that we have we use about 14,000 tenecteplase vials in Sri Lanka per annum, and we expect about 20,000 acute MI, similar to the UK number. So unfortunately, all you said needs to be given to more patients. So that is where we should go for. At the moment, only 6% of STEMIs get it in Sri Lanka.
2 patients get the primary PCI done.
Thank you.
And only problem with our system is our patients come late also. So when the patients come late, the effectiveness of thrombolytic therapy also will go down. So that's the problem. So I think the primary PCI capable hospital, now we have cath labs so in so many places. I think we have to promote doing the primary PCI, because then we will have better results, because thrombolytic therapy works better only with the first 3 hours. But after that, when the clots get the thicker and once get stabilized, after that thrombolytic therapy will not work. It's a sad part of it. So we still give, I know some places they give after 12 hours thrombolytic therapy and those things. I don't know whether it will work.
If I may just add to that, that grim scenario which I just mentioned, only thing, the good thing is that this was in 2017. So since then we have had the free ambulance service, and we have also had free stents, drug-eluting stents in the hospital. So on those 2 accounts, we are doing a return of that audit, and hopefully we'll see more primary PCIs are being done at the moment. And the cath labs have also increased.
So what's the mean age of the patients that come in with primary PCI here? So in the UK, it's 64. So I
can't give offhand. I think Dr. Patrana is here. We did an audit. Our mean age was, I think, between 50 and 60. I think
so my
it is
reading
younger.
of the situation in Sri Lanka is that it's
younger
it's a younger population. And therefore, to your point, I think these patients have more to gain from primary PCI because they have longer to live. So if you leave them with LV dysfunction, so I think Sri Lanka has more to gain from developing its primary PCI program, because your patients are presenting at a younger age with
and late presentation also.
And the late presentation, of course, compounds the issue.
Because sometimes we get 2 hours delay in transferring from the emergency treatment unit to the PCI lab. So that type of.
Do you have data on secondary prevention medication once they've presented?
There was a trial which we did in Kandy some time back, and also in Colombo. I think they are getting all 5 drugs at that time, 95% were getting it. So that's very good.
Our pharmacological therapy is fairly good, because our physicians are educated and they are on statins and antiplatelets and so on. But I think the first contact therapy should be improved. I think that.
The other thing that was really interesting was about the treatment of the non-culprit lesion. So this is, whilst the European guidelines, as you very neatly highlighted, actual practice in our centres varies considerably. So that there have been instances where people have done the non-culprit vessel at the time of STEMI, had no reflow in the non-culprit, and the patient has not survived. And that has left a real stain on complete revascularization. Because we think that for all of the trials, I think it was very operator dependent. So I know we did culprit, we did PRAMI in our centres, and operators were very selective. So they would put patients in the trial if it was 3 p.m. in the afternoon, but at 3 a.m., patients didn't get in. So I take the trial data with a pinch of salt, having seen how it's been practiced. I also know that when there were complex lesions to be done and patients were randomized, they were not done. And therefore the trial data is very, very selective. They are simple lesions. They are during working hours by and large, and it shows, you know, good results. In real life, when we try to replicate it, as I said to you, in our center, we've had 2 operators, did the non-culprit, got no reflow in the non-culprit, immediate after a STEMI in another territory, and the patients didn't survive. So whilst the data and the guidelines give a very clear indication, I still think it's a grey area.
Yeah, especially in our country, because late presentation, again, you have to be careful in revascularizing the non-culprit, because those are the people more prone to get no reflow.
So this is my point. You've got a STEMI, you've got a large STEMI, you've got microvascular dysfunction. Why would you want to do a non-culprit vessel and risk further microvascular dysfunction? So I have a very strong feeling on this. I think staged procedure, allow the microvascular dysfunction in the STEMI territory to recover, whether it's 4 weeks, 6 weeks, 8 weeks, and then bring the patients back.
Yes, I think in our setup, I think that is the best method.
I think that is the best method to practice in our setup. And only problem is, only thing that we have done is when you have simultaneous plaque ruptures, where I have seen about 10 patients.
No, there are exceptions. So sometimes you see a culprit lesion, the circumflex OM branch, and the LAD proximally there is a 99% lesion. Can you leave that and go? So in that situation, I think you can do it. But other situations, I think you can stage it and do it. I think that is the way we have to go. I think that because you saw that compounding factors are there, age, diabetes, our people are uncontrolled diabetes. Those type of people are not suitable to undergo non-culprit lesion in the same time.
So the postulation is that with counterpulsation, you get the Venturi effect, which draws the inflammatory markers and microemboli from the capillaries into the coronary sinus. So that it's a way of attacking. So you have blockage in the microvascular here, you've got coronary sinus here. So by counterpulsating, you have the Venturi effect, which creates a Venturi effect and sucks out microemboli and inflammatory markers.
So it increases the venous drainage of the...
Correct. And so there's a company called CoreFlow, and we're now doing antigrade, high pressure. You know, there's this study with the supersaturated oxygen. There's another study now where we're looking to give high pressure GPI in the microvascular. So antigrade and retrograde solutions to reducing microvascular dysfunction.
That is a preconditioning, is it?
No. So the preconditioning data was okay, but not strong enough to change practice. This is a catheter that goes in through the guide catheter, microcatheter, and then you inject at relatively high pressures, either a GPI solution, or just supersaturated oxygen. And the theory is that with high antigrade pressure, that transmits into the capillaries, into the microvascular, and you're pushing that blockage in the
inflammatory
correct
out.
Into the coronary sinus. And the counterpulsation is the retrograde approach, and this high pressure microcatheter is the antigrade approach. Yes, but with the counterpulsation, the history is because the surgeons, remember the Weinberg operation was to put grafts onto the vein very, very originally. So the counterpulsation actually is from history of 50 years back of coronary physiology.
Thank you very much for the very interesting lecture and the discussion which followed. In interest of time, we have to close the session now, and please show your appreciation in the normal way.